Good morning, everyone, and a very warm welcome to day three of CRAN's My Colorectal Cancer Coach Summit 2026. We are thrilled to have you join us again today, and thank you very much for being here with us. My name is Christopher Mammoliti. I am the National Patient Programs Manager here at CRAN Colorectal Cancer Resource and Action Network, and as well am a three-time early age onset cancer survivor. And I am joined this morning by our passionate and ever dedicated President and CEO, Filomena Servideo Italiano. Philomena, I'd love to turn it over to you to welcome our participants on this beautiful Wednesday morning.
Oh, thank you very much, Chris. Good morning, my friends, and welcome to day three of CRAN's My Colorectal Cancer Summit, an expert-led event that is serving as the capstone initiative for this very special month in which we find ourselves, Colorectal Cancer Awareness Month. For the past 2 days, a lineup of stellar experts from across Canada have been delivering empowering and informative, evidence-based presentations across a diverse range of topics that matter to patients and caregivers. In addition to training and certifying our colorectal cancer coaches, we also believe that this summit stands to educate our colorectal cancer patient community. Patient education is a critical step towards patient empowerment. Having free virtual access to reputable, expert-led, evidence-based information about specific topics of interest and relevance is invaluable and can enhance the patient's experience, reduce fear, and can certainly provide patients and caregivers with the tools they require to move forward in their life-altering journey. It is certainly our hope for you. So allow me to share that today's roster of expert speakers are absolutely outstanding. We will be exploring topics such as the medical management of metastatic colorectal cancer and the role biomarkers play in the management of that metastatic disease. The surgical management of peritoneal metastases will be discussed. We have an expert speaker addressing the interventional radiology treatments in metastatic disease, and the difference between PET, CT, and MRI will be explained, and why inclusivity is so important in cancer care. It's going to be a fantastic lineup of expert speakers, so I encourage you all, my friends, to join the sessions that will speak to your personal set of circumstances. Sit back and enjoy. And again, we very much appreciate you providing us with the privilege of hosting you today. Back to you, Chris.
Thank you so much, Philomena. Now move on. We'll start a little bit this morning with some housekeeping notes. To note, the summit is being recorded. Viewers cannot be seen or heard, so there's no need to worry about your mic or camera. All registrants will receive exclusive early access to the recordings before they become publicly available. To view today's agenda, please click on the Sessions tab at the top right-hand corner of your browser. All sessions will also be streamed in the lobby itself. Across the top navigation bar, users can also learn about our expert speakers. Visit our sponsor web pages and see bookmarked sessions within their personal itinerary. Some sessions will have additional resources available to download. Click on an individual session within the Sessions tab to view its reference materials in advance. Once you're in the meeting, click on the resource icon, which is highlighted here, to access downloadable resources. Please leave the lobby open in your browser during the summit. When each session ends, you'll be prompted to rate the session, and then you will need to return to the lobby to join the next session that's of interest to you. Should you experience any technical difficulties at all, our team are ready to support you. Please reach out to our communications manager, Alyssa Salmon, should you require any assistance. Very quickly about our amazing organization. For any new participants joining us this morning, I'll briefly introduce us. The Colorectal Cancer Resource and Action Network, or simply known as CRAN, originated as a grassroots colorectal cancer information support group back in August 2006, 1 month after the passing of Philomena's father, who was afflicted with widespread metastatic disease. Today, CRAN has proudly become a national not-for-profit patient-focused organization. We're governed by an experienced board of directors, and we're counseled by an expert medical and scientific advisory board, of which many members are generously participating in this event. At CRAN, we have 2 patient advisory councils, one of which is dedicated to the under 50 patient population, which I belong to, whose past experiences with the disease help to inform our program development to ensure our services are relevant and meaningful. In terms of our mandate, we champion the health and well-being of Canadians touched by colorectal cancer and others at risk of developing the disease. And we do this by providing 3 main pillars: support, education, and advocacy to both patients and their caregivers, which is a very important distinction. And this is intended to help improve a patient's quality of life as well as their longevity. CRAN has expanded its patient-focused mandate to serve multiple tumor type patients through our HTA patient evidence submissions, educational events like we're in today, advocacy initiatives, and some of our patient programming to ultimately reduce the burden of cancer in Canada, because this is our collective mission. As always, we take the opportunity to introduce our amazing coaches. This week we have introduced them personally, but we want to take a chance to showcase anytime we can. Our coaches are here day and night, ultimately ready to guide you and your caregivers as you live with or beyond cancer, and will offer compassionate support and evidence-based information, which we know is so critical and important. If you'd like to connect with your own cancer coach, please do reach out to me personally, and I will make sure you are connected promptly. Lastly, as always, just a personal thank you to our coaches. As Philomena says many times, you are absolutely amazing human beings, and it's an honor to serve and support alongside you. Okay, so today's agenda, to run through very quickly to give you a quick idea of what we will be doing today. We're starting with one of our favorite topics at CRAN, obviously something that's very important to myself as well: biomarkers in the management of colorectal cancer with Dr. Pollett, followed by the medical management of metastatic colorectal cancer with Dr. Gill. We then have a short break to reset a little bit before heading into our midday session on the importance of inclusivity in cancer care, a really, really important conversation with Dr. Medvedev. Following our lunch break, where we actually get a chance to sit and relax a little bit, we also have a very special presentation airing during the lunch. So on Second Look Cancer, a global colorectal cancer clinic trials finder with Dylan Eisenhower. Following lunch, Dr. Ortega will walk us through imaging in colorectal cancer, covering PET, CT, and MRI scans, followed by interventional radiology treatments of metastatic disease with Dr. Majumdar. Lastly, we finish the day with the surgical management of colorectal peritoneal metastases with Dr. Knapp. Please do get comfortable with your pens, your papers, your laptops, whatever it is your preference is. I will note, following each expert presentation, our cancer coaches will enter a 15-minute closed and interactive discussion with our experts so that we can ensure adequate knowledge translation and content acumen. During these gaps in schedule, we encourage our viewers at home to take an additional 15-minute movement break, or maybe even just grab a snack. All right, now we will get moving. Very quickly, I will introduce the one and only Dr. Aaron Pollett is an anatomic pathologist and co-director of the Division of Diagnostic Medical Genetics at Mount Sinai Hospital, and an associate professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. Dr. Pollett has a special interest in gastrointestinal pathology and pathology informatics, with the master's degree from the Department of Health Policy, Management, and Evaluation at the University of Toronto. He is the review pathologist for tumor-based registries constructed to analyze the genetic basis of gastrointestinal cancer. In his various roles, Dr. Pollett oversees the molecular analysis of solid cancers, as well as the development and implementation of molecular biomarkers. Please Take it away, Dr. Pollett, and thank you so much for being here with us.
As mentioned, I am an anatomic pathologist practicing at Mount Sinai Hospital in Toronto, and gastrointestinal pathology is my area of specialty interest. I don't have any financial disclosures. I do practice in Ontario. My talk has got a bit of an Ontario tilt to it. So if there's questions about specific provinces, I can do my best to answer it, but I will mention that because of the nature of my practice, I do know the most about what's happening within Ontario. I'll do an outline, just talk about what the handling for a pathology specimen is, what exactly are biomarkers, focusing in about biomarkers within cancer, touch a little bit about things that are emerging because this is a rapidly evolving space. And to give a picture of what's happening on the horizon that is not in the too far future. So when it comes to handling specimens, there is a standardized approach for handling all cancer specimens that happens within laboratory pathology labs, really internationally. And so this includes both the handling of biopsies, how they're embedded to ensure proper examination, and the appropriate assessment of cancer specimens. And this is called grossing. If you hear somebody refer to a gross examination, that's when the specimen is actually removed. And we've got a team of pathology assistants that are very well versed in examining the specimens to ensure that all the appropriate measurements are done and that sections are taken from specimens so that we can provide a complete picture, a complete report of all the required elements to ensure that the oncologists and the rest of the team have all the information that they need around pathology reporting. So to ensure that both the biomarkers that we're talking about are done in an accurate way, there's a number of what we call pre-analytic factors that are looked at. These are especially important in some of the biomarkers that are related to immunochemistry, which I will mention, but they also impact some of the other biomarkers like the molecular markers. And this includes things such as ischemic time, the time between which a specimen is actually removed and when it's placed in a fixative, the most common of which is formalin. And you may hear terms such as formalin fixed, paraffin embedded. It's the standard way in which tissue is handled. It's placed in a fixative to stop any degradation of the tissues, and then it is embedded inside the paraffin so that we can actually section it and do the examination. So to ensure that the tissue, the materials are in the best condition for examination, there's a lot of standards to ensure that these pre-analytic factors are done in a consistent manner. Specimens are handled properly, they're fully fixed, and then we have formalin fixed paraffin embedded tissue. And there are guidelines, and especially in the era of molecular testing, that exist and are followed within labs to ensure that specimens are the best quality for this molecular or other biomarker testing. And this is some pictures of just the tools of the trade. What we've got at the very top, this thing in blue is what we term the cassette. So the actual tissue gets placed in these cassettes when it is handled by the pathology assistants. The tissue is then embedded in plastic, and on the left-hand side, you've got 4 blocks of tissue. The very top right is probably benign tissue. The bottom, the top left would be benign. The bottom right, inside that block, that actually probably has a tumor in it. And so that is what the tissue actually looks like when it's placed in paraffin. And we can section through that. We actually cut it at the thickness of about 4 microns. So, half the thickness of a hair, or about we're talking less than the thickness of a nucleus or red blood cell, and then they're put on slides. And the right-hand side, we've got 3 slides there. And the slides are stained. The pink and purple stain is called a hematoxylin and eosin, or H&E stain, and that's our bread and butter for diagnosing tumor, assessing things like grade, extent, tumor type. And for purposes of the molecular, you can see that we actually outline in some of these areas with the tumor. And this will go up to the labs. We'll actually cut material off these paraffin blocks, take that area of tumor that's been identified by the pathologist, and scrape it literally off it, take the cells, extract DNA. From there, we can do our molecular analysis. The very top is some tubes, and that tubes collects either tissues that are then sent for molecular analysis directly, or collecting the tissue that's scraped off the slide. So that's our key tools. And then when it comes to the pathology team, as I mentioned, in addition to the standard ways of handling the tissues, there's standard ways of reporting. And often you'll hear terms such as synoptic reporting. There are a number of international standards. Within Canada, we use the College of American Pathologists Cancer Protocols, and that ensures that all required information regarding a cancer specimen is done in a standardized way, so that all the information is available and captured. There are other ones, such as the International Collaboration on Cancer Reporting, ICCR, and there's a lot of overlap between the two. They're not exactly identical, but within Canada, you will hear about synoptic reporting and the College of American Pathologists Cancer Protocols. So within these protocols, within the reporting, as we move to more advanced tools, there are guidelines that come out with regards to molecular classification. And so it becomes important for the pathologist to have all the required information to ensure that the classification, the reporting that's done on tumors are at a level to ensure that the proper subtyping classification of the tumor is done. And these, again, follow some very standard guidelines around the information needed to ensure that the tumors are properly classified. So, moving into the space and why everybody's here, and this is the biomarkers. So a biomarker is really any sort of characteristics measured. It's an indicator of biologic process, of pathologic process, or response to exposure intervention. So as you can see, biomarkers are actually a very broad topic, and it is anything that can really be measured or a sign that indicates a certain process that's happening within a disease. Now, here we're going to specifically talk about biomarkers related to cancer. And there's a lot of terms that get kicked around that really are sort of synonymous. That's cancer biomarkers, tumor biomarkers, molecular biomarkers. And when we talk about these, we're really looking at the actual gene sequences or proteins, gene products, or some other substance that provides us a specific information related to that cancer. The testing process, some people will call it tumor genetic testing or genomic molecular testing, genomic profiling, somatic testing to distinguish it from germline testing, which is actually done in the context of genetic counseling, and tumor molecular genetics. So there's a lot of terms which just add to the confusion when we talk about biomarkers. And while biomarkers are a large term, for the rest of the talk, when I refer to biomarkers, I really will be referring to those biomarkers specifically related to cancer. Given the breadth of what biomarkers are, they have a lot of utility within oncology. Risk assessment, there are some screening biomarkers. They can help for actually the subtyping or differential diagnosis related to cancers. Prognosis, prediction or response to therapy, which is probably one of the biggest uses for biomarkers right now in the sphere of oncology. and emerging areas around monitoring response to therapy or recurrence. So because the biomarkers have such a wide range of utility, they include such a broad category of or wide range of materials, it's really important that the biomarkers that are put into practice go through evaluation process. This includes analytic validation. You want to make sure that what is being measured is actually being measured within the labs in a consistent way. So you ensure that any labs that are doing the biomarker testing can pick up what they believe they can pick up. The next part is a clinical validation. So it's one thing to have a lab test. It's another to make sure that those results that you're seeing and reported for biomarkers actually have the clinical activity that you expect it to have. And the biomarkers that are put into practice have gone through a series of evaluations to ensure that they've got clinical validation. And then the third one is assessment for clinical utility. Because again, there's a lot of biomarkers, and it's important that part of the evaluation is to ensure that they will have the practical application within the clinical within clinical practice to ensure that it's not just generating noise and information; it is actually being used to help guide utility within the clinical setting. So, oncology biomarkers, and I'll start using some examples that are specifically related to colon. There are biochemical tumor markers, and I'm not going to go into those, but CEA is an example. There are proteins that are made within cells that can then be detected in the bloodstream through biochemical detectors. PSA would be a common one that would be used in the context of colorectal cancer. CEA is a protein that is made and can be elevated in the setting of colorectal cancer, other cancers, but also in benign conditions. So there are these biochemical tumor markers that I'm not going to focus in. That's a blood test and not specifically measured off tumor. The biomarkers I'll get to, we've got immunochemistry, and there you've got an antibody that's tagged to a protein. So it's really good for looking at proteins, protein expressions related to genes. And what we've got on the slide is, so brown is the most common sort of marker that will tag to an antibody to pick up what these antigens are. And you can see, depending where the protein is, it can actually have a number of different patterns. The very top left, the brown is within tumor nuclei. So we've got an immunochemical marker that's looking for proteins expressed in nuclei. An example, I'm going to get into this, the specifics in a few slides, would be such things such as your mismatch repair genes. When we use immunochemistry, we expect the nuclear repair apparatus to be in the nucleus, and so that's where we look for it. The slide here in the middle outlines cells. It's a membranous stain, and this would be something like a HER2. It's expressed on cell membranes, and we would look for immunochemical expression, and it needs to be on the membrane to be interpreted. And this far right one, it's got staining on all sorts of areas. It's cytoplasmic, it's a little bit of membranous, and something like a beta-catenin, which is expressed in different tumors. Actually depends where the immunochemical state is, alters depending on the disease state and is used. So our immunochemistry common marker, many labs can do immunochemistry, and it is done through the microscope, looking at where these proteins are expressed within the cells. The molecular biomarkers are the ones that, again, we're seeing a real expansion, a lot of interest in here. And so we've got genetic testing where we actually look at the DNA or the RNA from tumors. We can look at single genes, not done very often, but you can do single gene testing. Most commonly, it's panel-based testing where a series of genes are done using more advanced molecular techniques. And you'll hear the term NGS used a lot, next generation sequencing, which is really a blanket term for a host of different techniques where you look at multiple genes all at once using some back-end chemistries to be much more efficient as we look to ever expanding and increasing molecular and genetic panels for tumors. There is other mechanisms that exist through which testing needs to be done that can impact genetic expression. This is often called epigenetic testing, where the genes are actually turned off through a different mechanism. So the genes there's no mutation, there's no alternation in the sequence, but the genes are turned off through different mechanisms. For colon cancer, methylation is one. And so you can hear this epigenetics or methylation testing, where you've got a switch that's controlling the genes in the background. Other terms that are being used a lot, we've got comprehensive genetic profiling, CGP, which is really it's not a specific test per se, more of a concept or a large panel that can be done with a number of different companies. We'll talk about their CGP test that's available, where you've got a large number of genes being looked at that includes a lot of common tumor drivers. So it becomes important from the pathologist end to understand that not all comprehensive genetic profiling is the same. They often have some common significant overlap, but it's an area that is coming increasingly into the literature, and it's a kind of a concept that leverages NGS and our ability to look at large panels in the context of molecular testing. And while it's not quite in the mainstream yet for tumor testing, we do have other genetic tests that are being done for different conditions within the country. And whole exome or whole genome sequencing is a technique that is done. And it's possible you may see it within the context of somebody talking about what's molecular testing happening in this space. So the biomarker reporting, we've got all these different techniques. There's different sort of, I would say, strata or different types of reporting that is done. The easiest one from a pathologist point of view are those that are binary. Is it present or is it absent? Such as tumor have a KRAS mutation, does it not? Or is there MSI? Does the tumor have microsatellite instability or not? So those are the easiest ones from pathology, it's the easiest ones from a clinical point of view, and these are ones where it's just present or it's absent. There's other biomarkers where it's not just is it there or not, you actually need to know the qualitative or quantitative score. The biochemical assays will often have a level. So you're not just saying is CEA positive, you're actually looking to see what the number is. From the immunochemical point of view, there's a number of different scoring systems that is actually tumor dependent. So HER2, the scoring, the assessment, how it's done actually varies. So your approach to a HER2 scoring is different in breast cancer than it is in gastric cancer. And it will have a semi-quantitative number on a scale from 0 to 3 plus. And PD-L1, which is used in a number of different systems, including gastric, it's got a different cutoff, at which point people will often call something positive. But again, it's got a scoring system. So it's not just, is it there or not? You'll be actually looking for a number. So the biomarkers, it's important to understand them in the context of the tumor and understand, is it just a binary or do I have to look for a number? And so for gastric cancer, where PD-L1 is done, somebody's going to be actually looking for the score number. As the higher the score, the more significant it is as a biomarker. Now, taking a quick step back to the utility within the biomarkers for oncology. This is the slide that I mentioned before. There's a lot of different uses for these various biomarkers. The ones that we're going to really focus in and the ones that are done on tumors themselves include the biomarkers related to the differential diagnosis, ones that are helping you subtype, give you information related to that tumor. There are prognostic markers, and those markers that are done in the tumor to predict the likelihood of response to therapy. So the diagnostic, prognostic, and predictive biomarkers. So examples of those, so the diagnostic ones, the molecular subtyping for tumor. And we're not quite there for colorectal cancer yet. We do classify them as to being a broad class of something like microsatellite unstable versus microsatellite stable. But other disease sites, such as the endometrial cancers, they're actually using the molecular type to subtype tumors, where you can't fully characterize the tumor without doing some additional ancillary or biomarker testing. The prognostic markers will dictate or give you a picture of how one would expect a tumor to behave. For colorectal cancer, the prognostic biomarkers would include a BRAF molecular signal, as well as the microsatellite instability. With MSI high tumors, stage for stage being better prognosis, and tumors that have a BRAF mutation being more aggressive than those that are the BRAF wild type. And then we've got the predictive biomarkers, and these predict the likelihood of a response to therapy. They're also sometimes called companion diagnostics, and KRAS, NRAS, collectively sometimes referred to as ERAS, are examples of these predictive biomarkers, where having a mutation indicates that someone is unlikely to respond to a specific therapy and will actually be either required or help direct the chemotherapy that's being used for treatment. So it's the use of these biomarkers and that molecular characterization that's allowing this whole drive towards precision medicine or personalized medicine, where the prevention, the diagnosis, treatment are really tailored to the genes, proteins, substances of the individual, and that includes the individual as well as the tumor. So it's these biomarkers that are allowing the whole practice of precision or personalized medicine. So, and this includes both tumor and personal genetics. So again, let's step into colorectal cancer in particular. There's a number of very specific biomarkers that are routinely done in the Ontario context, which help determine specific behaviors or response to therapy for colorectal cancer. These would include what's, and I should have spelled this out, but the mismatch repair immunohistochemistry. And that is looking at a series of immunochemical markers to characterize tumors as to whether or not the underlying mismatch repair apparatus is working within the tumor. Those in which it is abnormal would be considered deficient or DMMR, as opposed to the proficient workings of the mismatch repair apparatus. This is highly correlated with tumors that are have high frequency microsatellite instability or microsatellite stable. So immunohistochemical markers, it is done on all colorectal cancers within Ontario, and it's probably that first line marker very commonly seen right now, really right across Canada. The next tumor biomarkers would be done in the context of metastatic disease and where chemotherapy is involved. And these include KRAS, NRAS, BRAF, PIK3CA, sometimes you'll see P10. And these are markers that are molecular in nature, so you're actually looking at the genetic sequence, looking for mutations in these particular genes. The KRAS, NRAS, in those cases, if there is a mutation, the tumor will not respond to anti-EGFR therapy, and so it is used to help direct treatment. The BRAF has a poor prognosis. Response to therapy and selection chemotherapy may change depending on what's available to the oncologist. I'll let any specific questions related to drug selection, I will defer to oncology, upcoming talks. And then PIK3CA, commonly done. It is a downstream marker of the same pathway. Occasionally impacts both chemotherapy choices, but there are some indications that some chemopreventative work with aspirin works in this in settings where it's found in these tumors, so can help direct management. The NTRK I have on a separate line. The reason I have NTRK on a separate line is because it is a tumor agnostic, meaning that it's not a specific colorectal marker. Any tumors that have a alteration, or it's actually a fusion-based or an RNA-based test product in the NTRK can be have specific therapy. But there are a small population of colorectal cancers in which NTRK exists, and it is done through a combination of immunochemistry and confirmatory molecular testing to help to direct therapy. And in addition to the tumor biomarkers, the personal genetics is highly important for the practice of this precision personalized medicine. DPYD test, gene testing or genotyping, is done in a number of provinces across Canada, including Ontario. I'm going to just talk about it a little bit briefly because there are some important issues to recognize with DPYD testing. But that combination of MMR, MSI also helps detect families, groups where there is an increased hereditary cancer risk. This becomes important for any screening, identifying families at risk, additional cancers. So that personalized genetics on top of tumor genetics really help determine the best treatment action related to any particular person with cancer.
Dr. Pollett, I'm so sorry to interrupt, but we do have a couple of new cancer coaches that have come on board. And so perhaps you're going to be addressing this on this slide, but do you think you can distinguish between reflexive testing, which is when MMR testing is performed, versus the molecular testing, which is performed for the metastatic patient, and just help them to understand the difference? Would that be okay?
Oh, sure. Yeah. So we've got a term called reflexive testing. And for reflexive testing, by and large, those are biomarkers that are done on every case. So it comes through, it doesn't need to be ordered. I'll just see the case, it's got colorectal cancer, and we'll do reflexive testing. Probably the best, easiest example to understand this one in a different context is breast cancer, where forever breast cancer is diagnosed, every breast cancer is characterized with estrogen receptors, progesterone receptors, and HER2. So it's just done, diagnosis, reflexive testing. Boom. For colon cancer, the only marker that we have that we would say would be done on every single colorectal cancer across the province for reflexive testing is going to be the mismatch of immunochemistry. And the reason for that is, in addition to directing potential therapy, the prognostic marker, and it's got a crossover with hereditary cancer. So individuals with Lynch syndrome have a genetic predisposition to forming cancers, in particular colorectal and endometrial cancers, that have abnormal mismatch repair expression. So it is done routinely by identifying those tumors and having people referred to genetics families prevent cancer. So it's It's also prognostic, so it plays a role from stage 2 right to stage 4 and can help direct that treatment. There is a role for immunotherapy. I'll get to that in a minute, but staying on that reflexive comment, in the setting of known metastatic disease, then molecular testing is done. So the problem that we have with the pathology group at the time of diagnosis, if you have a colon biopsy, so if you've got a liver metastases that's biopsy, if you've got a tumor resection, you see it in the lymph nodes, you know. But a tumor biopsy through endoscopy, a pathologist does not know if that's a metastatic setting or is that in a localized cancer. So their reflexive testing will not have the molecular testing done because it is an unknown. So the true localized stage 1 colorectal cancers, the molecular profiling doesn't change anything with management, so it's not routinely done. And so I would say the molecular testing per se is not reflexive the way that reflexive testing would be done for mismatch repair. So there has to be some indication. If it's no metastatic disease, the person's being scoped, put it on the requisition, communicate, and it can be done, but it will not automatically be done unless there's some known unless it's known that this is metastatic. That's where I've addressed that particular question.
Yeah. Cancer coaches, are you understanding the difference? In other words, you have a stage 2, stage 3. What's automatically done, in other words, reflexively, is the mismatch repair immunohistochemistry. Whereas your biomarkers don't get tested unless you're a metastatic patient. Did I summarize it?
No.
Pollett?
Yeah. And again, I'm going to use, again, I apologize. It's always that trick to say what's that key thing that everybody needs to know. But you don't have to be quite so dogmatic saying it has to be metastatic. Aggressive tumors, cancers where you know that there's going to be chemotherapy involved, those are fine. The ones that we don't want, saying that the reason that the molecular isn't done on every case, because the ones that truly are isolated, the stage 1s, the superficial stage 2s, where chemotherapy is not being considered, the molecular, and sometimes it creates noise and more confusion than it can be helpful. So that's why you just needs to be communicated. This is somebody, we're going to need chemotherapy. Please do the molecular. Yes, we can do it.
I'll just jump in with a courtesy reminder that we have 10 minutes remaining in the presentation portion of this section.
Oh, 10 minutes. Oh, good. Okay, I'm going to throw through the rest of the slides relatively quickly, and then there will be opportunities for questions so we can really dive into it. The only reason I have this sidebar on mismatch chemistry is, one, I do this all the time, and two, the wording can be a little bit confusing because it's one, when you're looking for a negative signal, it becomes trickier to communicate than when you're talking about the presence of something. Because the normal state for mismatch repair immunohistochemistry is that you've got staining. It is a repair apparatus. You want it to be there. The immunohistochemistry is going to pick it up. So the abnormal state, and that's on the top left-hand side, is where it's blue. That's our counter stain. So it's the absence. So communicating absence, well, two things. One, you've got to make sure that your test worked. And so you can only ever interpret it when you know that you have quality staining. And I would know that on this slide because the right-hand side's got good nuclear staining. So I know that it's working so that I can say that this tumor really is not expressing it. But then you have to use the right words, because when I say something is positive, from a pathologist point of view, that means that it's present. So positive staining to us means brown. So this is negative staining. If I say something's positive for MSH2 to a genetics group, that means that there's abnormality in MSH2. So positive and negative is really a term that we don't use. Intact, deficient, normal, abnormal, those are all fine. The other thing is that the mismatch repair immunochemistry, that apparatus works in pairs. So you'll actually see 4 different antibodies around, but it will be abnormally expressed with MLH1 and PMS2. They're both sort of lost as a group when you lose MLH1. So somebody will say it's MLH1 deficient, even though there's 2 markers that are gone. And so sometimes that wording can get confusing because you won't hear the word positive, you won't hear the words negative, and you'll say, but there's abnormality in 2 markers, but we're only talking about 1, and it's because they do have these pairs that are dominant. There's also overlap in the terminology. So the test that we do, one that's reflexive, that's done, that you should see on all colorectal cancers, is mismatch repair immunochemistry. And then we'll often talk about something being having microsatellite instability, MSI, being MSI high or stable. And these 2 correlate really, really well, but they're not the same test. For practical purposes, if there's abnormal immunochemistry, it's going to be MSI high frequency microsatellite instability. And if it's normal, it's going to be microsatellite stable. There are some subtleties in the background in genetics and so on. So you may be wondering, how come I'm getting all these terms and they all sort of mean the same thing? And that's because there's a lot of overlap in the literature and the way people talk about it. So we did one test, then we talked about a tumor being microsatellite stable. So it has a strong association with hereditary cancer, in particular Lynch syndrome, and there is an algorithm that happens. So for tumors abnormal MLH1, then there's additional testing to say what's the likelihood or which people should be referred to genetics. And so that is another reflexive test. If it's abnormal MLH1, the pathology community knows we've got to look at BRAF in that population, as well as MLH1 promoter methylation. The most common way it's turned off to say, is this just tumor or is there a possibility of Lynch syndrome? And so there's an algorithm. Any abnormality in MSH2, 6, PMS2 alone is eligible for referral for genetics in the province of Ontario. So if there is abnormality in the mismatch repair, if it's abnormal MLH1, there should be ancillary testing. Any of the other ones, then consideration should be made for referral to genetics. I've mentioned it's prognostic, and more importantly right now, it's also a predictive marker. So currently it is in some subsets where immunotherapy is used for tumors that have abnormal mismatch repair immunochemistry or MSI high. This may become a tumor agnostic indication. So any tumor that's got abnormal mismatch repair immunochemistry, if it's MSI high, then may be eligible for immunotherapy. So it is for a marker that's been around for a long time, it's remarkable how many uses it has. So a few other just general concepts. Context is really important. So BRAF is routinely done on all colon cancers in the metastatic setting with the other molecular. The BRAF, B600E mutation, those common mutation you'll see in BRAF, is not rare in colon cancer. In melanoma, there's actually directed therapy to that mutation. That directed therapy does not work in the setting of colorectal cancer. So it's important to recognize that having the same molecular change in different tumors may be treated differently. So it is not as simple as saying, well, we've got a targeted therapy, it's going to translate between diseases. So the context and understanding the tumor becomes really important for knowing the significance of what the molecular findings are. There are different testing methodologies that do exist out there. They have different sensitivities. So there's a lot of overlap, but the underlying findings and the way they report will be the same. And there is some variation in terminology. So you may see the term mutation, or you may see something that's called a clinically significant variant, a pathogenic change, an oncogenic change. So any of those terms are all synonymous for that there's an abnormality here that has clinical utility. So colorectal testing, all cancers mentioned, all colorectal cancer, that's reflexive, mismentioned here. DPYD genotyping for all patients being, all people being considered for your 5FU or specific chemotherapies is available. I'm going to do a quick slide on that in a second. I put stage 3, 4. So basically, any person where chemotherapy is being used, there's molecular testing. Selected cases for NTRK. So NTRK is not first line right now in colorectal cancer. It is not routinely being done. It is rare. So if NTRK is being considered, it is one that is specifically ordered by oncologists. And there's a screen with immunochemistry followed by molecular confirmation. HER2 is becoming more and more requested by oncologists. It's emerging. I expect that you'll probably see HER2 pretty routine within the next year. It has both an indication for a likelihood for response, but also directed therapy. And in fact, HER2 at some point may become a tumor agnostic marker. But I do expect that we will see it on colorectal cancers within the next year. As I mentioned, it's an immunochemical test. It has one of those quantitative scores. So you actually, it's not just seeing is it there, 0, 1+, it's negative. So it's not HER2 amplified. Your 2+ is equivocal, and there'll be some FISH testing, and 3+ is positive. So HER2 is something you like to see. Quick talk of the DPYD test. So looking for deficiency, but those that have a specific genotypes have a higher risk for developing toxicity. There's very specific genotypes that are looked at within the province. Not having one of the identified genotypes does not eliminate risk. So that becomes important. So we can identify some that will have increased risk, but we do not eliminate the risk. And there's a number of limitations, including some of the original studies looking at the typing, the genotyping, and that it's got an ethnic predisposition, so it does not work for all groups equally across this country. And so that's recognized. There's a lot of work that's happening in the space trying to determine which genotypes should be included. And there's a lot of work that has to be done with the oncologists so that they know how to adjust therapy based on the genotype. So there's communication that happens in Ontario with the conjunction between both the lab groups and the medical oncology groups, and oncologists know what to do with specific genotypes. All right, and I'm almost out of time. Just I mentioned the comprehensive genomic profile that you're looking at. These are large panels. There's a lot of overlap. They do focus on the tumor drivers. They're not all the same, but the advantage to them is they do have these tumor signatures that you will see. I already commented on MSI, but there's a couple other ones that you'll see: tumor mutation burden, homologous recombination deficiency, HRD, TMB. They play a role in some other disease sites, but and there's a lot of issues with those. As I'm running out of time, I'm not going to go into them. And then we've got some tumor agnostic targets, NTRK I mentioned, but there are some other emerging ones, RET, for example, NRG1. And again, we'll be seeing some more of these in the future. With these large panels, it is also possible that you will see a difference in the approach that centers use for reporting. All centers will report what we call these clinical significance variants, but some centers will report the tier 3 or those that have unknown clinical significance. So it doesn't mean that one lab tested it and one lab didn't. There are different approaches. There are discussions about what's the best way to handle these. But you will see some difference in tumors depending on the labs with the same underlying genetics. So again, just becomes important if you're seeing, well, what are they talking about tier 1, tier 2, as opposed to clinical significance. And the tier 3s, really, they're unknown. And so, and that's exactly what it says, the exact clinical utility assessment. Okay, I'm just going to talk about this for 1 minute, and that is the funding for biomarkers does vary depending on the province, and ultimately it comes from the provincial ministries, and they can direct therapy. For example, in Ontario, we've got a very specific genetics testing program that's responsible for the oversight, implementation, and funding for biomarkers. It's all genetics, it's not just cancer, but all biomarkers comes under that program. Other sites could be institutional, and you'll hear them talk about base funding, but there is variation of how that funding happens. There's work by Canada's drug agency, CDA, used to be CADIT, and they've created an advisory panel framework to assess cancer biomarkers, and they've had a couple meetings recently, and they've become very active in trying to standardize the approach to funding, building it right into the evaluation of drugs that are being evaluated, similar to the way that they traditionally did drug evaluation. So we will see some updates in the way it's handled across the country, but right now it is very provincially variable. And then just the last slide is some future directions. We are seeing an expansion of those tumor agnostic molecular directed therapies. We are seeing expansion in some of the panels that are being done with this move to what I would call this comprehensive genetic profiling. The reality is nobody does any single gene testing anymore. All centers are doing panels. They just slice off depending on the organs of the tumor and the key genes for reporting. And there's a lot of interest, a lot of discussion happening about what do we do about incorporating these larger panels. And liquid biopsy is right around the corner, where we can actually start looking for the tumor DNA that's circulating in the blood in different situations. And I expect, again, that we'll see a lot of this happen in the next year or two. So.
All right. A big thank you to Dr. Pollett for such an important, informative presentation on such a critical topic in modern oncology, and as you mentioned, healthcare in general. Our silent viewers can now head back to the lobby to join the next session, which will be taking place at 10:45 Eastern Standard Time with Dr. Gill, and our coaches can now head back, and we will see everyone again at 10:45. See you soon.